Hello, good day. My name is Tracy Weke, a University of the People student, Department of Bachelor of Science in Health Science. I am here to present my Capstone project report of HS 4991, and my instructor name is Shagun Vishan. The title of my research or presentation is Promoting Birth Preparedness Among Rural Pregnant Women in Enugu State, Nigeria. Thank you. Introduction. Maternal health is a serious public health issue in Nigeria, especially in rural areas. Many rural pregnant women have limited access to skilled healthcare, transportation, and correct health information. To add to this, honestly speaking, I would say that most African women living in rural communities are actually facing the same situation. Lack of good health facilities, lack of specialists or consultants to attend to pregnant women, lack of good roads, transportation is actually affecting our pregnant women in most of the African countries. Thank you. Nigeria accounts for nearly 20% of maternal death worldwide, with over 200 maternal deaths per 100,000 live births. Research shows clear difference between rural and urban women in birth preparedness and complication readiness. Study in Enugu State found that urban women are most likely to plan for deliveries in health facilities, while rural women often depend on traditional birth attendants who may not even have formal medical training. This is a fact. Upon where the globe is leading us today, but still, there are still our women out there in some of the rural villages suffering from this problem due to lack of resources, such as good road, as I mentioned earlier, good road, good health education, good information which will help them prepare during their pregnancy. Lack of good facilities where a pregnant woman can walk in and get a consultant or a specialist to attend to her. Sorry. Okay. This might this is my literature review, which says maternal health disparities. Maternal health remains a major challenge in Nigeria, especially in rural areas, due to poverty, long distance, and weak health system. That's weak health system. Health inequalities. Rural women often have poorer health outcomes because of limited health facilities, shortage of skilled workers and transport, as well as costs and barriers, etc. Rural-urban differences. Studies in Enugu State shows rural pregnant women are less prepared for childbirth and emergencies, while urban women plan better and access skilled care more easily. Quality of maternal health service. Rural women face long distance, poor facility condition, drug shortages, and negative staff attitude, unlike urban women who report better services. Policies and programs. Maternal health services exist but are poorly implemented in rural areas due to infrastructures and staffing challenges. Community engagement, involving community leaders, traditional birth attendants, and women group improve awareness, acceptance, and birth preparedness. Target population and rationale. The project focuses on rural pregnant women in Enugu State as they face the greatest risk. Community-based intervention can improve preparedness, reduce delay, and lower maternal death disparities. Okay, my research actually focuses on promoting birth preparedness among rural pregnant women in Enugu State. Okay, so I believe with readiness and preparedness of the health professionals who is ready to share information, to give out a rich information which will help our pregnant women in rural area to survive. They lack a lot of information which will help them during their pregnancy and childbirth. So with good resources and staffing, and a lot of staff who are ready to go into the rural areas to give information, a health professional who is well skilled, especially in communication, is needed to go into the rural areas to help our women with the information they need to prepare during pregnancy and after childbirth. Okay, the framework of my project: study design, comparative cross-sectional study. The project uses a comparative cross-sectional design to compare birth preparedness and complication readiness. Practice among rural and urban pregnant women at one point in time. The same semi-structured questionnaire is used for both groups to identify differences such as saving money for delivery, planning, transportation, and choosing a place of delivery. Sampling strategy: multi-stage sampling. Participants are selected using multi-stage sampling. This involves randomly selecting rural and urban local government areas, choosing communities within those local government areas, and then selecting pregnant women from antenatal clinics and community registered. This method helps include both clinic attendants and non-clinic attending women. Community engagement. Community engagement helps build trust and encourage participation. The project involves seeking approval from community leaders, working with traditional birth attendants, and collaborating with local women's groups to promote acceptance and understanding of BCRG practice. Okay. Ethical principle. Ethical standard guide the project, including informed consent, confidentiality, respect for participants, and fair inclusion of rural and urban women. Participants are assured that their information is private and that participation will not affect their healthcare service. Project milestone key. Milestones include community entry and stakeholders engagement, data collecting using interviewers administered questionnaire, and data analysis followed by community health education based on findings. Resources required. The project requires financial resources such as transport, printing, logistic, maternal resources, questionnaire, postal, stationaries, personal, research assistant, volunteer, TBAs, health officers, and Logically support transport and meeting venues. Potential risk and mitigation. Possible risk including low participants, poor road access, and literacy challenge. These are addressed through community involvement, flexible transportation plan, and interviewer administered questionnaire in local language. And then I have my data analysis study design, which are the community-based cooperative cross-sectional study, sampling method, multi-stage sampling techniques, then the stage 1, 2, 3, and 4. The 1 is selection of communities, rural and urban. 2, selection of wards. 3, selection of household, systematic randomly sampling. Then 4, selection of participants, ballot system for fairness. Community engagement, meeting with community leaders, traditional birth attendants, and local women group. Data analysis process, data cleaning and coding, descriptive statistics, frequencies, percentage, means, median, etc. Inferential statistics, chi-square test, multivariate logistic regression. Then the key points: rural-urban disparities, differences in BPCR practice, such as saving money and transport planning. Factors which influence preparedness. Factors influencing preparedness. Number 1, educational level, socio-economic status, healthcare accessibility. These factors are very, very important because educational level counts as number 1. Socio-economic status, I don't know, healthcare access is actually disparities in Africa because that's what the society believes. Okay, then I have my summary of the findings. Rural-urban disparities. Rural women were less prepared for birth and obstetric emergencies compared to urban women. Okay, BPCR practice, saving money. Rural women save at home, while urban women use bank or cooperative societies. Transportation. Urban women had pre-arranged transport plan, while rural women rely on family members. Knowledge of danger sign. Rural women knew danger sign but lacked practical preparedness and community support. Influencing support factors. Educational level. High education level associated with better BPCR practice. Place of residence. Rural residents linked to poorer BPCR practice due to distance to health facilities and poor road network. Access to healthcare service. Limited access in rural areas contribute to poor BPCR practice. Community engagement. Community engagement is the involvement of traditional birth attendants, women group, and community leaders. Improve participants and awareness. So here I have my conclusion. In conclusion, this project highlights the importance of promoting birth preparedness and complication readiness among rural pregnant women in Enugu State, Nigeria. Our finding shows that rural women face significant challenge in accessing skilled care and preparing for childbirth, leading to poor maternal health outcome. So by engaging communities and promoting BPCR, we can reduce maternal mortality and improve health equity. Let's work together to design and implement effective maternal health interventions that are tailored to needs of rural communities. Recommendation: strengthen antenatal education and BPCR training for rural women. This first recommendation is very, very important. We need health educators to go to our rural areas to help our pregnant mothers who are suffering in the rural areas. We need health education, qualified ones who are very good in good communication. They are needed in the rural areas to help our mothers, our women out there who are suffering due to lack of information and education. Lack of health education is actually a killer. Okay. Engage community leaders and traditional birth attendants in promoting maternal health. Then improve emergency transport system and access to skilled care. Target low education and high risk group with tailored intervention. So at long last, let's work together to reduce maternal mortality and improve health outcome in Enugu State. Thank you so much. Then I have my Thank you so much. Then I have my references. Thank you, Extractor.